I'd like to welcome everybody here this evening, and I'd like to thank all of you for coming to my district forum on the single-payer healthcare proposals. Linda Puglisi is the town supervisor of Portland, and she is very kind, and the people that work for Portland, as well as the other officials, to allow us to use this wonderful facility. It was an old school, and it certainly looks like a wonderful old school that people used to go to classrooms here. Or this probably was the cafeteria auditorium, right, together. The political battle in Congress to overhaul the nation's healthcare system came to a screeching halt last month as the latest effort to do away with the Affordable Care Act died in the Senate. The words repeal and replace are not so easy to accomplish, even if you state that it is your goal. I think we've all learned a lot about healthcare as the federal government has been discussing it throughout the summer months. However, while leaders in Washington were busy sparring with each other and looking at whether to trade in Obamacare for Trump care, New York has been involved in its own domestic healthcare policy debate. Could a statewide, single-payer, universal healthcare system work here, and could it be an antidote to our current healthcare ills? The New York Health Plan, which the State Assembly first voted on in 1992, and I tend to think that Richard Godfrey was an Assembly member there then, and several times after that, would establish the nation's first universal healthcare program by cutting through the complicated web of insurance policies to only use one single payer, the state government, instead of private companies and federally run programs like Medicare or Medicaid. Tonight you're going to learn more details about the proposals in the New York Health Act as our guests discuss whether or not single payer is a viable and effective option for the 20 million New Yorkers, and how the current multi-payer system could be converted into a single-payer one. And I hope you will find your own answers to these questions as we proceed through the night. I've actually left on, or my wonderful staff has left on your chair, it could be a blue sheet, it could be a different color because we were using up all of our colored papers, but it has questions about how you felt when you walked in the door, what was your feeling about the single-payer system, and then what did you hear, if you can think about what you heard through the night, you can put your name on it or not put your name on it, but what did you hear through the night from any of our speakers that may have convinced you one way or another or made you more firm in your position. It would be very helpful to learn how the audience is feeling, because we're not going to do a poll, so this is your way to let all of us on the panel know how people are feeling. Will a switch to this new healthcare model be better for patient care? I think that's one of our big questions. Will not having so many health insurance companies to deal with be better for our overall population health? And will single payer be economically sound for individuals and families by ultimately producing a lower per capita cost? I think we can all agree that health care is a fundamental right. How we go about making it affordable is what is at stake. My goal for tonight is to have a balanced pro and con discussion and to hear from some of the top experts in New York on the issue. We all need to be informed and take part in the discussion that is happening not only in our backyard in New York, but also on the national level. And let me direct you to other handouts. There is a, whatever color it is, bio on the individual speakers tonight, and a little bit of background about them. And also their contact information if you want to talk with them at a later time. And also just to remind you about upcoming events, I'm having an open house at my district office on October 20th from 10 to 4. during the day. It's in Austin, 2 Church Street. You can come in and talk about whatever you want to talk about, and I will absolutely be there all that time. Sometimes I'm not in the office for a whole day, but I will be there. And the other is we're going to be having a documentary movie, She's Beautiful When She's Angry, on December 5th at the Austin Library, and that's a panel, we're going to have a panel discussion, and that's about the time that I was moving into this area, and some of you were too, in the 60s and 70s, and what was going on in the area of women's rights. And we saw this movie in Albany. It's fantastic, and it's a great topic for discussion, so hopefully you might consider coming to that too. Also, let's be sure our cell phones are off. We are trying to tape this whole program, so cell phones don't make it as easy for people to hear. So that would be great. So our format tonight is each of the panelists are going to present their own or their organization's positions on single-payer health care before taking questions from the audience. And as I just explained, if you have a question, which I didn't explain, there's another white card. If you would just write down your question, and if you want to hold it up, one of my staff people, Lisa Hofflick, who put this all together, will come by and pick it up. Jen Tawil, who is my office manager, will pick it up. Lindsay will probably pick it up after she stops being a timekeeper. She's an intern in my office. And Laura Seitz is around in the back and will pick it up. And we will ask questions through the cards to our panelists. And I think we're going to start. First, I'm going to introduce everybody first. My distinguished colleague from the New York State Assembly, Richard Godfrey, more normally known as Dick, who is the sponsor of the New York Health Act. And in addition to being the longest-serving member of the Assembly, Dick has been chair of the Assembly Health Committee since 1987 and is one of the leading healthcare policymakers in the nation. Now, he started at age 23 in the Assembly, so he's not as old as you would have been anticipated. But we are grateful that Dick was able to come here to Cortland from his district on the west side of Manhattan. So he came up by train, and I tried to show him a little bit of my district as we went from the Austin Railroad Station up the Hudson River. Next we have Bill Hammond to my left, who is Director of Health Policy at the Empire Center for Public Policy. And Bill has written extensively about healthcare system alternatives and is skeptical that a senior payer system could work statewide or nationally. Bill has come an even longer way to join us tonight. He's based in Albany. And thank you so much for coming the 2 hours down. He was on Route 9, crossed over 84, but he actually said it was a beautiful ride. Right? Dr. Thomas Lee, to my left, has actually participated in a number of my press conferences over time on different issues like smoking in playgrounds and other health issues. Dr. Thomas Lee didn't have to travel as far as Dick or Bill, but we're just as grateful and honored to have him here. Dr. Lee is the chief of neurosurgery at St. John's Riverside Hospital in Yonkers, and is a past president of the Westchester Medical Society and the Westchester Academy of Medicine. He also serves on the New York State Department of Health Board for Professional Medical Conduct. And Dr. Betsy Rosenthal, we're honored to have her join us as well. Dr. Rosenthal is an active member of the New York Metro Chapter of Physicians for a National Health Plan, a group that advocates for healthcare reform. Dr. Rosenthal is a retired board-certified dermatologist and also a member of the clinical volunteer faculty of Albert Einstein College of Medicine. And now it's time to begin. I don't think I ever introduced myself, but I'm Sandy Galef, a member of the New York State Assembly, and I thank you all for being here at my town meeting. We're going to begin with some questions, and Dick Godfrey will go first. Single-payer healthcare. What does it really look like, and what would it cost? How do we set one up in New York while the rest of the country goes on with Affordable Care Act? Dick?
Well, thank you, Sandy, for bringing us all together. And I tell you, I've been in a lot of community meetings over the years on this topic. I think this is about the most packed room I've been at this kind of event. So congratulations to all of you for being here. You know, I start with a basic principle that every American should have access to health care. No American should be denied health care or have to suffer financially to get it. You know, we put ourselves into extraordinary contortions when we are focused on trying to take care of insurance companies and their finances. The one way to provide all of us with health care and financial security, and to do it in the most practical and most affordable way, I believe, is to take insurance companies out of the picture and to create an improved Medicare for all system. I don't see Washington coming close to doing that anytime soon, but a state like New York can certainly do it. You know, almost every problem that we have in healthcare, whether as patients or healthcare providers or employers or taxpayers, is made worse and harder to solve because we have an insurance company dominated healthcare system. They tell us what doctors and hospitals we can go to. They tell us what healthcare they will allow us to have by telling us what they will pay for. They really prevent us from taking control and responsibility for our own health care and undermine family financial security. And it's a system that is all rigged against working people because insurance companies want the same premium, the same deductible, the same copays, whether you are a multi-million-dollar CEO or that CEO's receptionist or the janitor in the building. That kind of regressive way of paying for healthcare is very destructive to almost all of us. Now, the Affordable Care Act certainly made improvements in the system, and nobody should want to undo those improvements, but its basic flaw is that it leaves us in the hands of the insurance industry. And that means ever rising premiums, higher and higher deductibles, and copays. It means more and more restricted provider networks that we have to live with or pay steep out-of-network charges if we dare go outside the insurance company's network. None of this is based on ability to pay, and it imposes real obstacles to health care and to our family finances. In a given year, a third of families with health insurance report having to go without health care for financial reasons, and in most cases, it was for a serious condition. A third of families report having difficulty paying medical bills. Those of us who have employer-sponsored coverage find that year after year, our employers are shifting more and more of the cost to workers, whether by making the workers pay more and more of the premium, or plans with higher and higher deductibles, which entirely come out of the worker's pocket, or higher and higher copays and more restricted provider networks, shifting the cost to those who are least able to bear it. And the cost is a lot higher than it needs to be. Insurance company administrative costs and profits are about 15% of the premium dollar. Healthcare provider administrative costs are about 5 times what they are for doctors and hospitals in Canada, where they have a single-payer system. All in all, administrative costs and profit add up to about 20 to 25% of the healthcare dollar. Money that doesn't help to make anybody healthy. And bad as it is, Washington is working to make it all worse, whether you're talking about cuts in Medicaid or privatizing of the Medicare program, which has been a Republican agenda for years, or undoing the consumer protections in the Affordable Care Act. The New York Health Act can make it better. It would provide universal, complete health coverage to every New Yorker. All the benefits of Medicaid and Medicare and more would be rolled into the program. We would each have complete choice of doctors and hospitals. Taking insurance companies out of the picture would provide net savings to 20 million New Yorkers of $45 billion a year. It would end the regressive taxes, in effect, that we now pay in premiums and deductibles and out-of-network charges that are not based on ability to pay. Instead, it would be funded fairly through a broad-based tax, progressively graduated, based on, in other words, on ability to pay, on payroll income, and on taxable non-payroll income, such as capital gains and dividends. Our analysis shows that 98% of New Yorkers would be paying less in those taxes than we are now paying in premiums and out-of-pocket expenses. Critical to this concept is that we would all be in the same boat for health care. And to me, that's not just a matter of fairness. I mean, I'm no more entitled to good health care than any of my constituents, or wealthier people than any of my constituents. But also important is that by having us all in the same boat, that is the best guarantee that each and every one of us and our doctors and our hospitals will be treated fairly. Because when people with wealth and influence make sure, as they will, that their health plan takes good care of them, the rest of us will be in their health plan and will benefit as a result. The New York Health Act will simplify life enormously for patients who won't have to be fighting with insurance companies and trying to figure out whether the lab you're going to get your blood test at is in or out of network this week. It will greatly simplify life and reduce costs for doctors and hospitals, who will have enormously lower administrative headaches and costs from fighting with dozens of different health plans. And they would be able to spend more of their time doing what they went to medical school to learn to do, which is to take care of us. Employers will no longer have to be spending an enormous amount of time and effort picking and choosing and arguing with health insurance companies for their workers, which would save employers about $2 billion a year. Now, any number of people will tell you that, oh, everyone knows a single-payer system is the only thing that makes sense, but oh, it could never happen. That's beginning to change. It's beginning to change first because the Affordable Care Act, as much good as it has done, has really highlighted the problems that still remain in an insurance-based system. Single payer is getting more support than ever because the debate going on in Washington, I think, makes it very clear that Washington is not about to solve any of our health insurance problems. They're actually going to make them all worse. It's surging in support because it's, I think, increasingly clear that if New York is going to defend itself from the onslaught coming from Washington, really the only way we can do that is with the savings and efficiency and better coverage that we can get with a single-payer system. We've seen more and more labor unions coming on board in support because they see that healthcare is increasingly an albatross around the neck of labor in labor management bargaining. The Assembly has now passed the bill in each of the last 3 years by a vote of better than 2-1. And so I think more and more people are coming to see that this is not some fantasy, that this is something that is really doable. And I think when people see it as something that is really doable, they're going to start asking their candidates and elected officials, why haven't you gotten on board and made this happen? You know, people, I believe, want to make a living, they want to get to keep some of it, and they want to be treated with fairness and respect. To me, that's impossible under the current system, but to me, that is exactly what a universal health plan like the New York Health Act can deliver for all 20 million of us. Thank you.
Thank you, Dick, very much. I'm so glad that so many of you are here tonight, but we haven't quite run out of seats. I know there's 1, 2, 3 over here. A couple of people are sitting on the floor. There are a couple seats right in here if you want to do it. Are there other seats in between that somebody can point out to me? Yes, there's one there. If you can take the poster down, somebody can sit there. And there's one behind. There's 3 in there. So I'd rather have people not have to stand. Do we have any more seats in the house, anyplace? No. We took them all out. We could take the heavy ones, but they're a little bit big. There's what? They're sitting on the floor.
No, I know.
No.
You can sit on the table.
Oh, can you sit on the table?
Not without single payer.
Okay, all right. So now we'll have Bill Hammond give a presentation as to what he thinks about the single-payer system.
Well, I'll start by thanking Assemblywoman Galef for having me down to this beautiful part of the state. I also want to thank everybody here for turning out. This really is an impressive audience, civic-minded citizens.
Raise your mic,
Is that better?
Yes.
So, I want to start by addressing what I think are some misconceptions. Single payer is not the same thing as universal health care. Single payer is a particular model for paying for health care. And it's not even necessarily the dominant model. There's a lot of the developed world well, Canada and the United Kingdom are the 2 big examples of single payer plans. But a lot of other countries in the developed world have a system of mandatory private insurance that's subsidized, and it's kind of a stronger version of what we have in the Affordable Care Act. So I happen to be a believer that we should work towards universal care. I've defended the Affordable Care Act. But I think that even if you think single payer is a good idea, which I don't, I think this bill in this state at this time is a mistake. And I have 7 reasons. First of all is the cost. It's enormously expensive. The supporters, a study done by a supporter of this plan said that the state would have to raise taxes by $92 billion. And for a sake of comparison, the state currently raises a total of about $80 billion. So this plan would more than double the total taxes, sales taxes, income taxes, the lottery, everything. It's more than double. And that's using a very lowball estimate of what single payer would cost. I think a more reasonable estimate would be $180 billion, or certainly a lot more than $90 billion. And so you're talking about tripling what the state government raises in taxes. And I guess that brings me to my next reason for being skeptical, is that most of that money would go to fix things that aren't broken. Well, maybe I don't want to go that far. But they would be going to buy insurance for people who already have it. We have people on Medicare would have to give up their insurance. People on Medicaid would have to give up the insurance they have now. People who have employer-provided insurance would have to give that up if this is brought to fruition. We have about 5% of the population is uninsured right now. It would not cost anywhere near $90 billion to insure those people. And it seems to me the more logical approach would be to attack that genuine problem rather than trying to replace the health care of every single person in the state. Another problem is that the spending that we currently do, which is too high, would undoubtedly go up under this plan because you're taking away the current systems of restrictions and co-pays and deductibles that he mentioned. They're a drag sometimes, but that's part of what's keeping our costs from going up even further than they are. There are legal objections to this. It's not clear that the federal government will relinquish the money that it gives us for Medicaid or for Medicare. It's not clear that large employers would cooperate with this. They have special rights under federal law. There's also particular problems that come from a state trying to do it, just one state trying to do it instead of the whole country. You could have a situation where we become the charity care provider of last resort for the whole country, and maybe even for other countries. If somebody can move here, somebody who has a very expensive condition and need a very expensive treatment, and they can move here and they can have access to the very best doctors that New York State has, with the taxpayers paying the full cost, that can get enormously expensive. And I guess my final objection is that if we learned anything from the experience of the Affordable Care Act, it's that we should have some humility about our ability to make changes to the healthcare system. How hard it is, how expensive it is, how politically difficult it is. And we're talking about doing this plan without anything like a serious, nonpartisan, independent analysis of what it would cost, what its impact would be, whether it's legal. There's no basic questions like exactly what taxes would have to go up by how much aren't addressed. Another basic question is what would happen to doctors' fees and hospital fees? Would they go up? Would they go down? Would they stay the same? So those are things that I think before anybody votes to pass a really radical change like this, you need to think it through. You need to get some serious numbers and some analysis.
Thank you, Bill, very much. Now, I think we're going to go to Dr. Lee. We're doing an alphabetical, actually. G-H-L. Okay. Dr. Lee.
Thank you very much. It's great to see all of you here and everybody taking an interest in our healthcare delivery system. As a physician and an active practice physician, I look at healthcare as 4 parts: access, affordability, quality, and also choices. Americans value all those important elements of the healthcare system. Now, in looking at a single payer system, we need to have the historical perspective, evidence-based data, as well as reality check to decide what is best to do for our state and our country. This is going to be an open discussion, an honest discussion of the issue we'll be facing if you were to have the single-payer healthcare system. It's not about slogan, name-calling, none of the above. I won't be doing any fear-mongering either. I do have to acknowledge that U.S. healthcare system is the most expensive healthcare system in the world. It has the highest per capita expenditure of over $9,000 per person. Now, but by emulating a system such as NHS, the British system, and the Canadian Health Act, CHA, I think we're actually pursuing a very misguided endeavor. NHS is running out of money. Last year, the budget was $180 billion. They're going to run over that easily by 4 billion, I'm sorry, it's by pounds, sorry, by 4 billion pounds. Now, they're trying to extricate themselves from the system, which they have experimented with for decades, and we are jumping head over heel first into that system. Is there something wrong with that picture? In Canada, where you have single healthcare system, where the federal government deals out money to the provincial governments, they prioritize care. Much like in Oregon, if you like that system, perhaps this system is for you. Diagnosis 1 through 325 will be paid for. 320 and 26, you have to go through a panel. In the British system, you have what we call NICE. I like that name. Whenever somebody brings up a sin on me, I always think hard about it. It's called the National Institute of Healthcare Excellence. It determines what procedure and treatment NHS will pay for. So any treatments above £27,000 a year from 2016, you will be automatically denied. You have to go through an appeal process. Right? Now, I think single payer system is a highly prescriptive solution for a very, very complex problem that the single payer system does not fix. I was enumerating some of the issues of NHS and CHA, but more specifically, we're looking at significantly prolonging waiting time. Just talking about facts here. In England alone, in March of this year, there were 362,000 patients waiting for longer than 18 weeks for hospital treatments. That is an increase of almost 64,000 from the prior year. Now, and also just over 95,000 of those folks had waiting time more than 6 months of treatment. Is that what we want to have in our country? If the answer is yes, I say by all means, that's where we should go. Now, number two, single payer system will foster anti-competitive behavior. The Affordable Care Act by itself has already consolidated the healthcare marketplace in the state of New York. Larger and larger hospital systems are getting even larger. They have become way too big to fail. They have absorbed all your community hospitals in this county, every single one, and the last one or two will be gone, probably within the next year or two. Now, we hopefully all believe that honest competition brings out the best quality in your healthcare and keeps everybody honest. That is the fundamental principle. And I think the current healthcare system will continue to drive the actual lower care providers into those larger systems, which cost the same treatment double, triple, quadruple. You don't have to ask me. Speak to the large big hospital CEOs. Now, many patients and physicians, and I always say that I'm an apologetic advocate for physicians and patients alike. I will say that the regulation from a single payer system will kill many small physician practice and the physician-patient relationship. What do I mean by that? When the federal government and the state government take over healthcare regulation as they have, for the most part, they invent tools to promote quote-unquote quality. And you and I both know that when you walk into your doctor's office, the doctor is looking at a darn computer screen. He or she ain't looking at you. Why is that? Because they are required to punch in all those check boxes to be considered practicing good medicine. As a doctor who actually takes time to talk to you and examine you, interpreting your data, going over tests with you, are being penalized. Unless you're in this big conglomerate where you can afford 5,000 PAs, a lot of secretaries to do these things. I believe that is the wrong direction you're taking healthcare to when you promote such a system. We all know these jargons such as value-based purchasing, quality of care, all the electronic health record. Unfortunately, what is being collected are process measures, not quality outcome measures. We're spending money on these healthcare companies, such as the electronic health record company, that does not give you anything in return. Now, I will say regulation is going to take physicians, many of them in the traditional mode of practice, out of business altogether. You don't have to look at me, look at what's happened in the marketplace already. Now, you say, great, let's bring this decision, centralize it to the state government, Department of Health, as the bill itself has proposed. I tell you, that ain't gonna work. The federal government, under HSS and CMS, have been trying for decades to push seniors into Medicare Advantage plans. Guess what? That's run by the insurance company. They do not want to run healthcare. They want to get out of business of running healthcare. Our brilliant state government, Department of Health, has been pushing all Medicaid, traditional Medicaid recipients into from fee-for-service Medicaid into, guess what? Managed care Medicaid. So if the state government and the federal government has developed the competency, expertise, and knowledge to run this program efficiently, they would have done it all by now. So we're going to develop this competency overnight. No, we cannot afford to experiment with our healthcare, my healthcare and yours, and my patient's healthcare. I am not willing to compromise for that. And last, I'm going to go over my time a little bit. Talking about cost for a moment. Vermont and Hawaii were two states that passed a single payer system. Guess what? They have not really implemented. Number two, the state of California, our compadres, very progressive state like ourselves, they aim to pass a single healthcare system in their state legislature. They had all the votes. Their Senate budget projection was as follows. The healthcare system in the new paradigm is going to cost approximately $395 to $400 billion for the state of California, almost twice our population in the state of California. So the number that was talked about earlier is about right. The current expenditure is approximately altogether private and public sector $200 billion. That would have meant that you had to raise about $195 to $200 billion more to pay for that single payer system. This is the Democratic controlled Senate and Assembly's own budgetary office coming out with a number. All right? So it's a very progressive state like ourselves. And guess what? The discretionary budget for the state of California, except for entitlements, is $190 billion. So you're going to have to double that in order to pay for this new system. So having said that, I do believe that patients and doctors deserve a healthcare system which is patient-centered, disease-centered. We take care of patients, we can help you save money by the process, best possible care. Regulation is helpful, but over-regulated promotes the demise of the more efficient and lowest healthcare delivery system. Cost containment, assembly line care that's being promoted under the current systems such as DSRIP, Summit Accountable Care Organization, is not the best prescription for our healthcare system. Thank you.
All right, and our last speaker, Dr. Rosenthal.
Hello, I'm very happy to be here tonight to speak to you about something about which I am very passionate.
As close as possible.
Okay, can you hear me now? So I'm very happy to be here and to see so many people turning out for this. And I have spent 50 years as a physician. And when I started in medical practice, it was very different from what it's like now. I went to medical school, I wanted to make people better, I didn't particularly want to run a business. But I was a dermatologist, and I still am, but I'm retired from private practice, and now I'm still teaching at Albert Einstein Medical School, and I'm using my energy from retirement to promote single-payer health care. I joined Physicians for a National Health Program because I found from all my experience as a physician, as a patient, as a mother, as a Medicare advisor, that they had the right answer to fix our very sick, I won't even call it a system because it really isn't an organized system. It sort of grew like topsy, and I think it's the way to fix our non-system of medical care. And why do I think that? First of all, I think it's a crime, it's a moral issue. It's a crime and a disgrace, and it's immoral that our rich, rich country cannot provide medical care for all its people. And our system is inefficient, terribly expensive. Our reliance on private, for-profit insurance companies is causing tremendous waste and inefficiency. This is what happens in my office when and people who think that the insurance companies aren't taking over. When Obamacare started, we thought, well, this is going to be great. He's really for single payer. But what happened is he was afraid he couldn't pass anything unless he went to the industry and asked them. And he asked them, what do you want? And they said, we want a lot of new customers. We want everybody to have to buy our terrible product. And that's what happened. So it's not a government takeover of healthcare, it's a private health industry takeover of healthcare. So what we need is to get rid of the private for-profit industry that is adding cost but no value to the system. As a doctor, here's what happened when I sent a bill to, oh, and by the way, this is not radical and this is not new, and this has been studied for many years. We have a single-payer system that has worked in this country for over 50 years. It's called Medicare. It works great. And most people are very happy with it. And that's what we need to do, just expand it, improve it, and give it to everybody. It's not a big experimental thing. We don't have to reinvent the wheel. Medicare was introduced over 50 years ago, no computers, and guess what? In 1 year, it was up and running smoothly. And it still is to this day. Here's what happened to me when I was in my private office, and I tried to get paid for my services. I would bill an insurance company with whom I had a contract to be in their plan, so I would take whatever rates they required. So I would send a bill, and then they would say, oh no, you didn't tell us about your patient's hangnail for 20 years ago, or you didn't dot the I or cross the T, and you have to resubmit. And they would do this 3 or 4 times. This is for work that I had already done. Finally, after 3 or 4 months, they would say, oh, well, we know we have a contract with you to pay you $100 for your work, but if you agree to take $70, we'll pay you now. That's how they operate, okay? How does Medicare operate? You send them a bill, and guess what? They pay you. So people who say, oh, well, the insurance companies, they say it's better than Medicare. No, they don't. Because Medicare actually pays you. The insurance companies, maybe, someday. I mean, dealing with insurance companies has made now more than 60% of physicians are in favor of single-payer program. They are tired of spending their time fighting to get coverage for what they think their patient should have. They have to keep asking, begging for coverage for a treatment that they think is the best treatment for their patients, and then the patients can't afford the pharmaceuticals that they want to prescribe because the pharmaceutical companies can charge whatever they want. If we had a single-payer system, we could negotiate with the pharmaceutical companies as one big unit of New York State and get the prices down like the VA does. So it's just a total no-brainer. Anybody who studies the economics of this, it absolutely makes sense to have a single-payer system. And people say, well, we'll have rationing. Well, you know, we have rationing right now in the healthcare system. Guess what the rationing is based on?
Profit.
Right, how much money you have. In this country, we get, and in this state, people get the medical care they can afford. In other countries, in Europe, they get the medical care that they need. Sure, some Americans get the best medical care in the world, but lots of them don't, and lots of them don't get any. Lots of people have to think twice, 5 times before they even want to bring their children to the doctor because they're afraid they're going to go bankrupt. They're one job loss or one illness away from bankruptcy, and people don't even know what their insurance covers when they're healthy. When they get good and sick, that's when they find out. So I think there's 3 things stopping us from getting this. It's very feasible. In New York State, we can do it. We're very, very close. We're only 1 indictment or 1 vote away from having a majority in the Senate. We can do it. And now is the time because everybody is worried about their health care ever since Obama came into power. Everybody is afraid. So here's what we have to fight against. We have the industry. It's very, very powerful. It's a very, very powerful lobby in Congress. And everybody gets money from them. Number 2, we have to fight the idea that the government can't do anything right. I mean, I have patients tell me all the time, oh, when I talk about this, oh, the government can't do anything right. Then I would say, well, what do you think of Medicare? They say, oh, Medicare, that's great. Is that a government program? This is what people think. And thirdly, we have the culture here of this country is not solidarity like it is in other countries in Europe. Everybody here, it's, I'm okay, Jack. You take care of yourself. You take care of your stuff. I'll take care of my stuff. And don't tell me what to do. But I think as more and more people get tired of worrying about paying for bills, when more and more people are afraid that they're going to be left out in the cold when it comes to getting health care, this is something that is very popular now. A majority of people, when you explain it to them, you say, if we raised your taxes a little bit, but you wouldn't have any medical expenses, do you want to do that? And they say yes. And people would be charged by their ability to pay, and we would get the health care that we need, and health care would be treated as a human need, as a social need, and not as a commodity or one should be made a profit. We can do it. Now is the time. You have to convince your legislators that you won't vote for them unless they give it to you.
questions, I know Jen has been picking up cards in the audience. Any questions that you would have for the speakers? If there's any specific speaker that you want to question, just put their name on it. We're not calling for questions from the audience. We're doing it through the card, so I know there's another card down there. But with any of our panelists, before we get into, we've got lots of questions here, just like a few minutes for a response to anything? Dr. Lee.
Not to respond to anything. I think I spoke about talking about reality and facts. I'm sorry. I would like to just bring your attention to the lovely Medicare program all our seniors love, and for a great reason. There's no gatekeeper of traditional fee-for-service Medicare, as you know, and you can see as many opinions as you reasonably believe in need and get your treatment without pre-authorization and pre-certification. That's one of the great advantages of the Medicare system. However, the reality is that based on a number about 2 years ago by CBO, I believe the number and the HS and the Medicare Trust Fund trustees, the average lifetime contribution by your employers and yourself into the Medicare system, we'll talk about that number in a second. We're going to say that, did you earn it? The answer is kind of, but not really. That's a reality check, and that we ought to be aware. Number one, the average lifetime contribution by your employer and yourself into the system is about $135,000. That's a heck of a lot of money for people that work their whole life. However, the reality is that the average lifetime expenditure of Medicare per enrollee is just about over $300,000. The Medicare Trust Fund, based on the Medicare trustees, they were given another year of reprieve, so now they will go bankrupt in 2029 instead of 2028 because the GDP has picked up a little bit. So it's a lovely system, it works well, but even that by itself is not sustainable in the current form.
Yeah, well, first of all, part of my lifetime contribution to the Medicare program is based on the fact that I've been paying into it for, I don't know, almost 50 years. And what I was making 50 years ago was a lot less than someone who has the same job that I had 50 years ago would be making today. And 50 years from now, the person who has that job 50 years from now will be making a whole lot more. That's why what I might collect in benefits from Medicare is more than my lifetime contribution, but that doesn't mean the system is unsound. Does it operate close to the edge financially? Of course it does. It ought to operate close to the edge financially. Otherwise, people would be screaming that it's raising money that it doesn't need. Any public program ought to be running close to the edge financially, and they all do. That's why we have a legislature and a Congress that every year look at a budget. In the insurance world, insurance companies pay out as little as they possibly can. They don't operate on the edge because they make extraordinary profits at our expense. Almost everything we've heard this evening, I haven't heard anybody really explain what value we get from insurance companies. I mean, we've heard that there are many other countries that have tightly regulated insurance companies. Almost all of them are required to be nonprofit insurance companies. But what benefit do those countries get from the fact that they operate through insurance companies? I haven't heard the answer to that question. Now, the closest we came to an answer was, well, they impose co-pays on us, and that helps to control utilization. Well, for people who find the co-pay hard to pay, yeah, it may control utilization, which means that when your doctor recommends care that's really important for you, if you can't afford the co-pay, you're one of the 1/3 of American households with health insurance that went without health care last year. And we've heard about waiting lists. If you're one of the households with health insurance that went without health care last year, most of the time for a serious condition, you weren't on a waiting list. You were just shut out. You were on an infinitely long waiting list. In this country, we don't keep track of that. So we have to say, oh, we don't have waiting lists. Well, of course we do, because we have people who are completely shut out of healthcare that their doctors recommend and that any doctor would recommend, but they don't get because they can't afford the copay or because the doctor who they really ought to go to is out of network and they have to pay the whole thing out of pocket. That's our current system. And I haven't heard any explanation of why that's good for us.
Can I just, there, two questions. Do you need to respond?
I got a couple comments.
Okay.
Defending the insurance industry is a thankless task.
Get close to the microphone.
But I guess what I would point out is that a lot of what insurance does is just processing, like making sure that the person that you're paying actually delivered a service to a real patient. And that's a huge logistical task. One, we do have a single payer system in New York State in the form of Medicaid, and it was infamous for not properly performing that task. The health department did it, before that the social services department did it, and it was notorious for the amount of fraudulent and abusive billing that went on, which, I mean, there's different estimates of it, but it's almost certainly in the billions that's being misspent. You would get clinics that would open their doors, they would have patients come in, they would diagnose them with something that needed a drug treatment, they would prescribe the drugs, but then the patient wouldn't actually need the drugs, they would just be sold on the street. So what the private insurance, one function that they play is to stop that from happening. And in fact, Medicaid has outsourced a lot of its processing to managed care companies, and as a result, its costs have gone down. You've added a layer of middlemen to the system, but the per-person expenses in the Medicaid system have actually been under control better in the last few years than they have through most of the history of the program. And there's evidence that the quality of the care has actually improved. And I guess in terms of the people who are shut out of the system, I think those are the people that we should be focused on. The people who don't have any insurance or who are underinsured and they can't afford the copays and deductibles, those are the people who need our assistance. I have private insurance. I'm able to afford the premiums. I'm able to afford my deductibles and copays. I'd rather go on with that system than throw it out the window and start over with something fresh.
All right. Okay.
I don't think it was the government that was so hot to get rid of health care that they pushed it all onto private companies for Medicaid and Medicare. So I think it's the other way around. The private companies saw a cash cow and they wanted to get on the action. And when you have, and the way private companies compete in this country is how they can best avoid paying for sick people. You cannot make a profit insuring sick people. You can only make a profit insuring healthy people, and everything they do is to try and avoid paying for care, and they spend a lot of money paying people to deny care.
All right, I have a lot of questions that are coming in. We're trying to put them kind of together, if possible, into questions. And maybe we can have as quick a response as possible from everybody so we can get through as many as possible. The first one is, and I have to tell you the reason I actually decided that I should have this forum was because I was getting so many emails in my office about healthcare. Single payer, no single payer, whatever. So it was my constituents who drove this meeting. But this was one of the emails that I got, but we have two questions here. I hear that people protest that single payer is socialized medicine. You have to dispel this notion. I have another one here. I've heard that the British and Canadian systems are examples of socialized medicine where the service providers are paid by the government, I thought the model of single payer being proposed is not socialized medicine, but a system whereby the middleman is cut out, and those are the insurance companies, and the providers work for themselves but get stipends from the government through taxes, etc. Can you clarify? Can we do a little clarification on this, or is this a hard one to clarify?
No, easy. Yeah, Britain has the National Health Service, where doctors and hospitals work for the government. That is properly called socialized medicine. The Canadian system is completely different. The Canadian system is very much like traditional Medicare, which is to say doctors and hospitals in Canada, many of them are private, some of them are public, like Westchester County Medical Center is a public entity, but the payer is a single public entity. The healthcare provider system is the same healthcare provider system that we would have today. So you could call that social insurance the way Social Security or Medicare is social insurance, but it is not socialized medicine, it is social insurance. So you go to the same doctor you go to today, the same hospital, or actually you'd have more choice of doctor and hospital because an insurance company wouldn't be telling you who you could go to. They would be paid instead of being stiffed by the New York Health Act rather than trying to squeeze money out of an insurance company.
You don't have to, you just.
Just in clarifying the Canadian Health Act of 1984, it is a federally funded program where the federal government of Canada doles out money to the provincial government based on their assessment of needs, and the provincial government carries out the task of healthcare delivery. One little known fact about a Canadian health system is that you either have to be all in or all out, unlike the Medicare system that we know of. As a physician, Medicare, participating in Medicare, or even the hospital for that matter, a physician can choose to opt in, opt out of the Medicare system and still be able to take, not opt out, but out network of Medicare, still be able to take care of Medicare patients. In the Canadian system, unless you opt in, you cannot take care of the national health patients at all. You have to be completely out or completely in. As I said, that is a highly descriptive system that's very, very different from what our country is used to. So it gives you zero flexibility for the patient and the doctor. You either have to ascribe to the rule or you get out of the system altogether. And I think that that type of prescriptive solution gives people no choice. I want quality, I want choices, and I think in some ways, yes, insurance companies are the gatekeeper, they would be the bad people. Guess what? They do have to, at some time, narrow the network to an extent such that they can ascertain the quality, but yes, they should provide enough specialists in primary care to care for their insured. So the all in, all out is not something I think is a great thing, and neither do I believe that the prioritizing ranking point system that they ascribe to the Canadian system is what this country, like MedPAC or IPAC tried to do, is something that we want to follow the footsteps of.
Okay, I have a question.
The Canadian Health Act operates province by province. Each province enacts a health plan. Their federal government says that if you have a health plan that meets the basic principles of the Canada Health Act, offering coverage to everyone, no copays, no deductibles, etc., no financial barriers to care, we will pay a portion of the cost. Similar in many ways to the way the Child Health Plus program operates. It's not a federal program. There is federal matching money to the provinces. No province has a system in which the province runs the healthcare system. And, you know, in terms of provider networks from insurance companies in this country, yes, every insurance company will tell you that the network that they have created because they really are your friend, and they're selecting the quality doctors in town to force you to go see. I get a lot of letters from doctors about provider networks I have never, ever heard from or talked to or gotten a letter from a doctor who told me that he agreed that the insurance company's provider network was based on what was good for the patient. Because they're not. They're based on what's good for the insurance company. And I guess if I were an insurance company, that's probably what I would do. That's why I will never be an insurance company.
All right, I have two questions kind of related. One is for Dick Gottfried, but this is for anybody. Governor Cuomo is withholding $380 million due to public hospitals,
Billion.
money due to
Billion.
public hospitals.
No, sorry.
With $380 million, right? For charity indigent care. What will prevent this type of underfunding under single payer? The fastest growing part of medical costs in New York State is long-term care. That's another issue, which primarily paid for by Medicaid. This system is subsidized by underpaying direct care workers. How will single payer cover these services? And then there was another question, when you consider assorted federal programs such as Medicare, Medicaid, Social Security, and others such as infrastructure, we never come in as budgeted, so I guess this is all about money. Do we have enough money to do this? Why should we consider that the New York Health Act would actually come up as budgeted? So I think this is
Yeah.
all about the money issue.
Yeah, well, the Health and Hospitals Corporation that the administration is holding money back from treats almost exclusively poor people. Poor people in our society are easy to kick around. If the governor were doing to Mount Sinai, or to NYU Medical Center, or to Weill Cornell, if he were trying to do to them what he is doing to the New York City public hospitals, there would be hell to pay. And that's my point when I say we would all be in the same boat. What will guarantee, and there's really no other way to guarantee it, that my doctor and your doctor and all the doctors of all the people who couldn't make it here tonight will be treated fairly, and that we'll be treated fairly, is that we'll be in the same plan with Mike Bloomberg and Governor Cuomo and everybody in the legislature and George Soros. That's what will make sure that we and our doctors and our hospitals are treated fairly. And if somebody can come up with some other mechanism that will help make sure that 19.9 million New Yorkers will be treated as fairly as 1% of New Yorkers, if you can think of another way to help ensure that, I'd like to hear it. I haven't heard one yet.
Well, we have a question for Dr. Lee. The Affordable Care Act is not working well. It depends on insurance companies. What you proposed as an alternative, so I guess that could be for New York, an alternative. Do we have an alternative? Then Bill.
I think the issue with the Affordable Care Act is a multitude of issues. It tries to please everybody, and guess what it did? It pleased nobody. Many of the issue with the Affordable Care Act is that it was ambitious but not ambitious enough, such that in the economic downturn, you decrease the enrollment requirement for federal poverty level to 220%, a federal poverty level, and now they're figuring out that as the economy tries to recover, the feds can no longer afford their 50% bill, or the state can no longer afford a 50% bill. That's why all the state program like district is there. What is the goal of district? I attended the first district, which is design system, incentive payment system, something of that nature. The goal is to try to reduce cost of the Medicaid system as a primary endpoint. Guess who the plan was drawn up by? KPMG. It's not drawn up by the Department of Health. We were called to the committee to approve the plan drawn up by KPMG. And guess who was advising the hospitals, insurers, large medical practice on the other hand? KPMG. So I think you have a very ancestral system such that we need to make sure that we get a system that is fair. Yes, everybody has put into the system the ones that can, and nobody wants to admit it. We're talking about equality of healthcare. Nobody here was born equal. Just a reality check. We all know that. Life is not equal. Life is not fair. We need to provide safety net for people that cannot afford it. But we cannot provide a Cadillac care. Our Medicaid system is the most expensive Medicaid system in the United States. Over $10,000 per capita a year. 10,500, I think is the projection. That's about the same as Medicare. Sick elderly folks that need a lot of care. Something is wrong with that. We need to have a more somewhat tier system that takes care of everybody, because we do not have unlimited money. I would suggest a tier system where there's essential health care benefits, tier benefit. We are not here to provide Cadillac care for people that can't afford it. We're here to provide as good a care for those folks that cannot afford it.
Bill, did you want to say something on whatever it was?
I wanted to go back to the very excellent question about the $380 million, because I wish I had thought of it. The New York City hospitals that are being denied that money, those are owned and operated by the city of New York. The doctors and the nurses and the custodians who work there are all employees of the city of New York. It's, in theory, the city provides it with enough money so that it can, in addition to what it gets from Medicaid and private insurance and Medicare, in theory, the city is there to provide with the extra money that it needs to do its job. However, the city is, those hospitals are in financial crisis. They have a lot of patients who don't have insurance, and the city is struggling to pay that bill. The state, another branch of government, is supposed to provide the city with money. The state is looking at a loss of funding from the federal government. There is no private insurance company intervening here. This is entirely one branch of government and tax dollars that are moving up and down the chain and getting lost. And the city hospitals are suffering from that. So I'm not sure how that is some kind of indictment of our insurance system. It's an indictment of government's ability to manage health care, is how I would say it.
All right, we have a lot of cards on money.
I'd say it's an indictment of a system in which poor people are in one boat and wealthier people are in a different boat.
Okay, so we have a lot of questions on money, but I'm going to turn to something that's a little different, and this is about a specific issue. What are the pros and cons of single-payer health care in addressing the current opiate epidemic, as well as the general problems of addiction and mental illness? I thought this is interesting because I don't know whether it would show a difference between if we were in single-payer and not, about taking care of drug crisis. So is this relative? Would there be different services? We know what we have today.
Yeah, today we have insurance companies that have to be, in some states like New York, really wrestled to the ground in order to try to make them deal appropriately with mental health problems, drug abuse problems, etc. And even with all of that wrestling to the ground, we still can't really hold them in line, in part because, their lawyers are at least as smart as our lawyers, apparently. But if you look across the country, there are a lot of states where people are beginning to notice that it's because they expanded Medicaid that they've been able to get decent services available to a lot of families that have real opioid abuse problems. When the governor a year or two ago was signing the bill to impose some more restrictions on insurance companies, he said something that I quote frequently. He said, the insurance company is a business. They're not your friend, they're not your uncle, they're not your doctor. If they can get away with not paying for something, they'll do it. Simple as that.
Any other?
Our current New York State mental health system the Assemblyman is correct. It's mostly shouldered by the Medicaid system, with OASIS as the overseer of the provision. Our New York State mental health system, is under the auspice of OASIS, which look after folks with substance abuse, alcohol abuse problems. Now, it has long been a stretched system because the funding has always been suboptimal, because the resources were hardly ever there, and many institutions that provide such services, many of them are actually doing at a loss. Now, the hope is that as more insurers come online, recognizing the importance of drug addiction, substance addiction, that they have increased their coverage of such services. Now, yes, you can have a single payer service system that continue to cover that, but even for Medicare, there's very little coverage for that. So we just have to recognize that there are different formulations of single payer system, including the VA system, which is a great example of a single payer system that unfortunately did not go so well. So as we go forward, the issue is if you make your system so unique from the federal system, I think you're going to have problems with program integration as well as funding determination, because Medicaid is a joint federal-state program, and many of the programs require federal waivers or federal approvals. We all know that. So I think this needs to be a more coordinated effort on the federal side, not a state-only effort, just from a logistical standpoint.
I'd like to
This is
just
about-
very quickly, just about the reason why I think that drug addiction programs would be better in a single payer system is you can't make money from them, and no insurance company wants to take it on because it's not a money-making proposition. So if we had it for, if we had a single payer system, and it would be covered, and then we would actually save money because people would be treated, and then they would be able to be tax-paying citizens after that. But it's not something that insurance companies want to take on. Taking care of sick people and people with big needs is not something that insurance companies want to take on, because it's not profiting.
All right, I have a question here for Mr. Hammond and Dr. Lee. You're both opposed to single payer, but didn't give any indication what they think would lower prices and develop better care. So what do you support? Do you agree with Medicaid for all? When do we talk about access to health care and no longer discuss access to insurance?
Mr. Hammond, may I tackle this one first?
Can't hear you.
I'm asking for a sidebar from Mr. Hammond. Yeah, I'll return to the mic. I think there's great ways of tackling healthcare costs. We're not talking about it. We pay the highest prices because 50% plus of the retail healthcare expenditure profit come from the United States. What does that include? Pharmaceutical, biological, medical device, robotic, computer science that's integrated into healthcare. We are an affluent nation, so most of these companies derive their profit more than 50% from our country. I think as a matter of fairness to our citizens that we need to take care of, that we should ask the developed world. No, I'm not asking for the third world folks who cannot afford HIV drugs to shoulder their costs. Absolutely not. That is not justice or fair. However, one of the great ways of equalizing the playing field is for our society to have a fair reimbursement for these companies providing innovation for these devices, for these drugs, that they make their money also from other developed countries, Japan, Western Europe, Australia, New Zealand, and China. Yes, they are a rich nation, and if they're going to enjoy the fruit of these companies' labors, and our country's labor for that matter, I think it is only fair that they pay their fair share for these devices and treatment. And by doing so, you will equalize the prices of these treatments across the developed world. And that is only fair. That is part number one. Right now, our federal law prohibits us from negotiating with drug makers device makers, biological treatments, genetic treatments. We do not have that luxury. They do not have the legal authority to do so. We can certainly pass sensible legislation at a federal level to enable our government and our insurers to do that. I think that is a logical middle ground approach that they can continue to innovate and make a buck to go forward and innovate even better for us.
Right.
The notion that drug companies will lower their prices to us if we can somehow hoodwink Europe into paying them a whole lot more, I don't understand that. And I don't understand how I will feel better knowing that people in Europe are going to be as miserable as we are.
Share the misery.
And you know, drug companies are going to charge us as much as we let them charge us. The fact that they are also going to be gouging Europe is not going to make them lower our prices.
All right. So let me just ask, is there a country that has a successful single-payer system? What would be the country that is that?
Canada, Taiwan, Australia. I would say primarily Canada, because of all those countries, they're the one that is most like us and has a system that is closer to what we're recommending for New York. Incidentally, Taiwan adopted their system when they were still ruled by their center-right party, not their center-left party. And a few years ago, I visited Taiwan and had a meeting with representatives of a dozen or so major U.S. corporations that have major operations in Taiwan. And I asked these Americans who had been living in Taiwan for about 10 years each, I said, how do you like the healthcare system? Thinking I might get an earful. They all said they love it. It's wonderful. And these are capitalists living in Taiwan, loving their single-payer health system.
Okay.
I must respond to that because
Okay.
I'm from Taiwan. And I am here. I must say that my father was one of the ministers in Taiwan in those eras of healthcare design and national government consolidation. I think it faces, it's a good system, good labor insurance, good universal coverage, part contributed by employers, part government, part labor. Now, the issue is similar to the British system and in part way to the Canadian system, such that they are also running a tremendous deficit. And they are also in the risk of going under just the same. So good services cost money. So there is how much you can save, but there's also how much you should save and should not save. Because how much are you going to value a human life with a nice system of $27,000 pounds a year? Or some decision is going to have to be made. And until our citizens have made that determination, I think it's premature to jump into something that we don't know what we're getting into.
Okay. Now let's talk about doctors. Will doctors be able to opt out of being in a single-payer system? You may have answered that. I don't know. In a number of states, concierge doctors, there are in a number of states, I think we have them here in New York. No, maybe we don't. Connecticut. We have, I haven't been to that.
I go to one.
You go to one, okay. Will doctors be able to practice that type of medicine? And also, will quality doctors leave New York State if the single-payer system is put in place? Why would they stay if they can get reimbursed more for the same procedure in New Jersey, Connecticut, or Pennsylvania?
I'd like to take that one as a doctor. Okay?
Okay.
First of all, doctors will be able to opt out. They just cannot get paid for things covered by the New York State plan, just the way in Canada. In other words, my specialty is dermatology. I think a lot of dermatologists would opt out if they want to do all the stuff that's not covered by insurance right now. I mean, a lot of them do that. They just do the cosmetic stuff and just pay out of their pocket. So doctors will be able to do that. They'll just have to have rich patients for patients. That's it. But to think that the only thing that doctors think about when they decide where they're going to work and what they're going to do is just how much they're getting paid is a big insult to the profession. Lots of doctors now would be happy to be paid a little less if they didn't have to spend their time fighting with insurance companies, and if they knew that their patients would be able to get all the care they need. My husband works at the Veterans Administration, and he doesn't ever have to worry that his patients aren't going to be able to afford the drugs that he prescribes for them or the treatments that he thinks are necessary, because money doesn't even come into it then. So there's other things that doctors look for in their practice besides just how much they're earning. And in Canada, doctors earn very well and they don't have a huge overhead. I mean, what is the biggest group of employees in the doctor's office? Is it people who are providing care? No, it's all the people doing the billing, and you have to pay for them. So if we didn't have that burden, we could earn a little bit less and still do very well.
A friend of mine told me that when she was growing up, her father was a physician, and that when Medicare was being debated, he was adamantly against it, argued about how oppressive it would be, et cetera, et cetera. But she said she noticed that after Medicare kicked in, birthdays got a lot better.
I would just like to add a couple of things as a practicing neurosurgeon. I provide universal health care to all the patients that walk through the door into the emergency room, both. In fact, I'm not a participating provider of Medicaid because the office visit would pay me $5 or $10, which is more than the cost of me hiring someone to collect it from the Medicaid vendor or managed Medicaid company, one or two. So I provide those care for free, and I'm proud of doing so because it's a service to the community. And for my practice as a neurosurgeon, Medicare, take this, is 1/3 of my cost of doing business. Every time I take care of the folks that's disabled on Medicare or senior citizen that's disabled, I lose money. Guess what? I do it because that's my calling to continue doing so. I'm one of the fewer Medicare providers, as you call us, in Westchester County. But so it is, on the other hand, if you go to a degree where you have a system that really does not pay for even overhead of the system. Now, folks are talking about, I got to hire this builder to do this and that, with the insurance company, getting pre-service, getting payment, handling, and all of that. I heard they're paying. I do the same thing every day. My staff does the same thing every day. But if you're looking at a truly monopolistic system, if you have a single entity that is in control of all aspects of provision of health care, what it's going to do is going to set up these rules that's going to make you have to hire 10 people to comply with the rules. Otherwise, you'll be penalized. Does that sound familiar to any doctors or healthcare workers in the room? Nurses, you are on that computer clicking on things all day long. You are not providing care. You're spending money fulfilling the hospital, the healthcare system, ensure the government's requirement. Otherwise, you will be penalized. And you're a bad doctor for not doing that. Now, is that really the way we want to do this? Monopoly is bad enough in insurers. Imagine monopoly as a Department of Health. I think that's not something what I'm striving for here. I think we got to have a happy medium of trying to cover everybody, and both on the individual level, on the practice level, on the hospital system level, to get the rest of the folks their safety net properly set up so they can get care for profit.
I wanted to point out that there are, in addition to the insurance companies, there are other businesses involved in the healthcare industry, and that would be the providers, the hospitals, the doctors, the rehab centers, the pharmacies. Some of them are not-for-profit, but others, most private practice physicians are for-profit partnerships or companies. And they have financial incentives too. Under the traditional so-called fee-for-service system of paying for care, the more care you provide, regardless of quality, the more money you make. And there's even perverse situations where provider makes a mistake, causes an injury, the patient comes back, needs more care, and the doctor gets paid twice for providing the original erroneous care and then for fixing the mistake. That system is one reason why both costs were high and quality was uneven or poor in many cases. And that is basically what the New York Health Act would bring back. It would be, everybody would have a right to go to the doctor of their choice, and the doctor would have a right to provide the care that he or she thinks is necessary. And so it would be a pure fee-for-service system, at least to start. And I'm not sure how you could ever get away from fee-for-service in a system where you guarantee the right to access every doctor. There's no network restrictions, there's no co-pays. I don't see how you would get away from fee-for-service in that environment. I think the better way to move a healthier direction is to do what's called capitation. This is a bit of jargon in the healthcare industry. And not being a doctor, I'm a little nervous to get into this because I know it's probably controversial. But the idea with capitation is you pay a set fee for a system of providers. Usually it's a group of doctors and hospitals together. Take a set fee to provide all the care that that patient will need in a given year. And then the incentive becomes to take the best possible care of that person, to control the costs and provide the best care. And if you could figure out a way to set that capitated fee based on quality, so that the companies that do the better care and deliver a healthier patient get paid more, that would be kind of the ultimate ideal.
You know, to me, if I have to choose between a world in which a patient goes to the doctor and gets the health care that the doctor recommends, versus a world in which a patient goes to the doctor and gets the health care that an insurance company recommends, I go with number one. And that's the first point. Second point, the New York Health Act is not wedded to fee-for-service. It very explicitly provides for the creation of alternative payment methodologies. It doesn't specify what those would be, because I don't think it makes a lot of sense for the legislature to try to do that. There are a lot of other ways to pay healthcare providers. And what Bill suggests of a capitated payment to an integrated system of doctors and hospitals that then divide up the money among themselves, I think may well make an enormous amount of sense. But any set of design elements for paying healthcare providers can be either run to run those providers into the ground, or can be run in a way that helps to promote sensible health policy. That's why I think it's important that how we pay doctors and hospitals be designed not by an insurance company whose only motive is to return money to its stockholders, and that is their legal obligation. I'd rather that the payment system be designed by an entity that is accountable to the public and that is focused on what is good for the public. And two features that help guarantee that that would be its focus is, number one, that we would all be in the same boat, and number two, ultimately the board of directors, namely people in my line of work and Sandy's line of work, ultimately have to get reelected by people like you. And to me, that's a large part of why I think a publicly accountable and publicly run universal system is the one that makes sense.
All right, let me talk about money here. We have a lot of questions up here. I'm going to tell you, we're not going to get through all of them, but we're going to make copies of all of them to give to all of our speakers, so they know the next time they're asked to be on a panel, all the things that you've asked. How do you counter the numbers cited by those saying single payer would require massive tax increases? And our state has a $4 billion deficit, MTA is a deficit, and cannot maintain systems. How can we trust your estimates? You stated, Mr. Godfrey, you stated that insurance companies keep 15% of profit, I guess it's as profit, of their premiums as profit and for administration. How can you also say that your plan has 0 co-payments and out-of-pocket, yet be providing all of the care while costing less than insurance? I guess it's about the money. I know there are some handouts. I know Dick Godfrey did that handout that's in the back, and I don't know whether anybody else brought handouts, to talk about the financial aspect.
Well, the $92 billion that Bill referred to in tax under the New York Health Act sounds like a lot of money, but it's $45 billion, which is to say about half of that $92 billion. Again, $45 billion is money that we are now paying out of pocket that would be saved. So it's $92 billion instead of $137 billion that we're currently spending. So if you bring down costs, you're bringing down costs. The fact that the check goes to Albany instead of to wherever your insurance company is based, I don't know about you, I'd rather be paying 137 times something. I'd rather be paying 92 times something than 137 times something. And secondly, that 92 billion would be more fairly distributed so that the wealthiest New Yorkers would be paying a higher percentage of their income towards that than middle and low income New Yorkers. To me, that's fair. And yes, healthcare is expensive. Today, we spend way more than twice the state budget on healthcare. We would spend a lot less on healthcare under the New York Health Act. The other part of the question, how do we deal with not having copays? Well, as I said earlier, copays only help to restrict utilization when they are imposed on people who either can't afford to pay the copay or can barely afford to pay the copay. There are people in my district who not only own one $13,000 Hermes shoulder bag, but own a half a dozen of them, each in a different color. I have a lot of people like that in my district. For those folks, a $5,000 deductible or almost any amount of copay makes no difference. It's not going to control their utilization of healthcare. But people who make $50,000, $60,000, $70,000 a year in a household, for those folks, a $5,000 copay, $5,000 deductible, and copays on top of that is almost like having no health insurance at all, because they will never be able to spend enough money to satisfy the deductible. That's the problem with copays, and there's no way that the patient can say to themselves, gee, $200 copay for this MRI, do I need it, do I not need it? How do I know whether I need that MRI? And why should whether I get the MRI that my doctor tells me I really need depend on whether I think I can pay for it? If somebody ran for public office saying that whether your child can take algebra should depend on whether you can chip in towards the several $1,000s a year it might cost us to help hire the algebra teacher. If somebody ran for the legislature on that slate, I don't think they do very well. Now, since Betsy Voss became the U.S. Secretary of Education, some people have said, gee, Dick, haven't you read the paper? But I'm not talking about winning a national election. Here in Westchester, if you suggested that your kid only gets to take a foreign language, after all, how educationally necessary is a foreign language? So we're going to charge you $1,000 deductible if you want your kid to take a foreign language. I don't think that's a good model for funding public education. And healthcare is, I think, part of life, liberty, and the pursuit of happiness, just like being able to have your kid learn algebra.
I guess I'd like to just say that if you want to pursue single payer, I think you need to be realistic about what it's going to cost. And Mr. Godfrey has just suggested that we can cover every single person in the state. They can go to any doctor they want. The doctor can order any treatment he wants. And the state can pay the whole bill without even a minor contribution from anybody else. And it's going to save money. I just don't think that's plausible. Bernie Sanders, during last year's campaign, said the same thing. He said, we can do this nationwide, Medicare for all. We can insure everybody, no co-pays, any doctor you want, any hospital you want, and we're going to save money. And a think tank called the Urban Institute looked at that. And the Urban Institute is not a conservative think tank. They're basically a democratic think tank. And they looked at his plan, and they said it would actually increase federal spending, total federal spending, by about 60%. Now, admittedly, that's replacing some of the spending that the private sector is doing. But they said overall health spending would go up substantially. So there are arguments to be made for single payer. There are fairness arguments. There are efficiency arguments. But let's not kid ourselves that it's going to be less expensive than the status quo, unless you get into some of the negatives that go with single payer, which would include a lot of rationing, a lot of wait times, and also just a lot lower salaries for people in the healthcare industry.
There's a question for Betsy. Would there be any changes in my Medicare charges, drug charges? And then there's a secondary question, actually for Dick. How would this one-payer system help snowbirds? Will our surrounding states be forced to file claims to New York? It's a side issue. What happens to Medicare? You had mentioned, actually, Dick, at one point something about Medicare, but Betsy, you want to start? What do we do with seniors that are concerned about Medicare?
It's expanded and improved Medicare for all, so they would not pay their Medicare fees that they're paying right now. They wouldn't have the Medicare Advantage plans, and they wouldn't get the deduction from their Social Security that they're getting now. And they would get a lot more things covered than they get now. So it's better.
Yeah, Medicare recipients would make out extremely well in a couple of ways. Number one, the New York Health Act taxes would take the place of Part B premiums. We would pick that up. And most of the income of seniors would not be subject to the New York Health Act taxes, like Social Security benefits. The benefits under the plan would be richer than Medicare because it would provide full coverage for dental, hearing, and vision. There would be no co-insurance, etc. If you spend time out of state, if you are still a New York resident, the New York Health Act provides that if you are temporarily out of state, it would pay your out-of-state providers, or if for clinical reasons you need to go to an out-of-state provider. For example, in a large part of Dutchess County, the nearest hospitals are in Connecticut. We would pay if you go to a hospital in Connecticut. Or if you leave the state and are no longer a resident, if you're in Florida, the Medicare program that you would have today if you went to Florida would still be there for you. And so for Medicare recipients, I think all around it would be a dramatic improvement. There are a variety of legal ways that New York could absorb or wrap around the Medicare program and deliver on those guarantees. If we had more time, I could explain a lot of the legal mechanisms. The bottom line is that Medicare recipients would receive everything they are getting now and more so. And I think the economic analysis that we've had done demonstrates how those numbers really work. And central to making those numbers work is the 20 to 25% of the healthcare dollar that now goes for administrative costs on the payer and the provider side, and to insurance company profit, almost all of which we would no longer have to spend. That's an enormous amount of money that would be made available to pick up the coverage that people now are not getting or are paying for out of pocket.
I just want to remind you all, you do have a sheet on your chair. If you don't fill it out tonight and you feel like filling it out the next day or whatever, just send it to my office because I really appreciate that very much. And we hope to have a DVD so that if you want to hear this all over again, obviously I need to because you can't run a meeting and hear everything. I really think this is a wonderful discussion and it is such a difficult topic. And we know what happened in Congress, I guess, because it was such a difficult topic. It's hard to find the right answer, but I hope a lot of questions. My panelists were great. I don't think we've ever had such a great. Thank you so much. And if you have any questions for any of the panelists too, you have their contact information on that pamphlet that you can get to them or to me. I just want to thank you so much for being here and for Portland allowing us to be here and my marvelous staff who helps with everything. Thank you all very much.
I go TV. And go TV.